just to set the stage, I want to maybe start with Drs. Epperla, Durani, and then Fenske and Dr. Armand. Let's talk about 2025 newly diagnosed advanced stage disease patients. I'm curious how in your groups are approaching these advanced stage disease patients. Have you guys completely moved to Nivo AVD? If you have done so, are there any patients where you may not use this regimen? And obvious would be somebody with clinically significant autoimmune disease, but beyond that. So is Nivo AVD your go-to regimen? Where would you not use it? And in your institutions, is there a role for BRCAD that Philippe was mentioning?
I'll start off. First and foremost, that was fantastic talk, Dr. Armand. I really enjoyed the talk. And coming back to your question, Dr. Hamadani, I think we have widely adopted Nivo AVD as the frontline treatment in patients with advanced stage Hodgkin's. And as you rightfully alluded to, definitely there is a group of patients, especially with severe autoimmune diseases, that we try to preclude usage of checkpoint inhibitors. And in those patients, the discussion is about using BRCAD versus BV AVD, because again, I don't want to discount the data with BV AVD. I mean, that's the only study that has shown the overall survival benefit thus far. So definitely, again, I'm not going to open the can of worms about which is better. Obviously, with the BRCAD, as Dr. Armand said, the data was fantastic. The PFS rates were, phenomenal. That has never been seen thus far, but still, I think the discussion about BRCAD versus BV AVD still holds true. But the patients with autoimmune diseases, patients who are on immunosuppressive medications for whatever reason, patients who are on high-dose steroids for whatever reason, I think those are the specific groups of patients we are trying to use non-checkpoint-based frontline treatments.
Yeah, I would agree with Naren. We all kind of celebrated when the NCCN guidelines were updated and everything that we could, be able to freely use Nivo AVD in our advanced stage patients. And I think autoimmune disease, there's a spectrum too. I think we have a lot of experience and evidence from our solid tumor folks who've been using these drugs a lot longer. And, they have been able to successfully implement these drugs in certain cases, even in patients with autoimmune disease. Maybe they're not having active autoimmune disease on, immune suppressants and things like that. So I think there's a spectrum, but that's one group. I think the other group that we do need to discuss is the elderly subset, the elderly frail subset who's not anthracycline eligible. And I think in that situation, I don't think we know what the best standard of care is. We had the Evans protocol, we have BV Nivo, but I think there's a lot of question mark about, what do we do with that elderly anthracycline ineligible cohort, and would love to hear from the panelists what they think about that too.
Yeah, I wouldn't have too much to add other than I think that throughout the sort of community, it's the move from AVD or BV AVD to Nivo AVD was not a very difficult transition. Most people are used to giving checkpoint inhibitors, whereas BRCAD is more like going back to escalated BIACOP, which many, even lymphoma specialists, haven't given that regimen for many years. And I think they already mentioned the groups we might want to avoid it. And I would say that the patients I did give Nivo AVD to, it's not always an easy regimen to get people through. And you can have LFT abnormalities, you can have all the different, inflammatory complications can arise. So you definitely have to be on the lookout for all of those things. And I do, in a way, it would be cleaner if we did BRCAD, because then we preserve checkpoint inhibitor for second line, where it really seems to work particularly well. But it's hard to ignore some of the more recent data with Nivo AVD. So I think that's catching on in the U.S. as the preferred regimen.
Okay, I'm a contrarian, so that's why they have me here. I'm a contrarian. I think BRCAD is getting short shrift in the U.S., and I think it could have been predictable based on practice pattern, right? It's the same as ABVD, BIACOP, it's always been like we walk in our own footsteps. But at least, I have never given Brecad, by the way. So, but just to build the argument for it, right? So it's a regimen which has, for most patients, only 4 cycles of therapy. And the anthracycline dose per cycle is lower than ABVD. So when you think about long-term toxicity of frontline chemo regimen, most of it's cardiac. Nivo might have other long-term toxicity, like thyroid in particular. Yeah, it's easy to deal AE, but it means the rest of your life you're on thyroid replacement therapy. It's not that uncommon. I see a lot of patients with thyroid dysfunction. So those long-term side effects are almost certainly going to be reduced with PET-adapted Brecad. Because Brecad is not just Brecad, it's a PET-adapted. And it may be that in the future we can do PET-adapted Nivo-AVD, which might be an even better solution, but we don't have that now. So I think, and the PFS of Brecad, again, is just outstanding. And it's not going to be the same with Nivo-AVD. We already know the 2-year PFS is less than the 4-year PFS. Now, different patient population, you can't compare, et cetera, but still it means the best cure rate that we have today based on randomized trial in advanced stage Hodgkin lymphoma is Brecad. And I understand from colleagues who have given it that it's not like giving Biacop, which I hated to do. Biacop was very tough regimen. As I understand, it's not the same. And so I think it's worth actually a conversation with patients. Yeah, you're going to suffer more while you're on chemo, but the cure rate could be higher. It certainly simplifies second-line decision, as Tim was saying, and you might be done after 12 weeks of therapy. 12 weeks of therapy, right? So, and also just to, on that last note about PET-adapted, the other part about the PET-adapted is I think our PET adaptation is not so good anymore because our PETs are very sensitive. So I think there are too many patients who go on the 6th cycle. Once we figure that out better, which already people have done with like MTV, stuff like that, I suspect it will be fewer than a third of patients who need the 6 cycles. So all that to say, I wouldn't be so quick to dismiss Brecad, and I would offer it to patients still, but I haven't had anybody take me up on it yet, so.
Urshila.
So I'm young enough to never have have given Biacop, and I understand that Brecad, dacarbazine, maybe less fertility concerns, but are you going to recommend then fertility preservation for patients if you're going to put them on Brecad?
It's a great question. So yes, but I would recommend it with Nivo-AVD too. So I'm pretty, I'm over-aggressive in recommending fertility preservation in Hodgkin for a couple of reasons. First, Nivo, or checkpoint in general, there is actually data that it impairs ovarian function, both animal model and some suggestive human data. We don't really know the answer what happens when you give 6 cycles of Nivo. Then there's the fact that if you, in Hodgkin, if you miss with frontline therapy, you're almost definitely going to make patients infertile with second line. Now, with these regimens, the risk is very low, but there's no time often and no opportunity after frontline chemotherapy to do fertility preservation. So if you have the financial resources, if patients want to wait, especially for young women, different from young men, I offer it. And it's possible that Brecad for 4 cycles, again, may not be more gonadotoxic than Nivo-AVD. The last part about this is the substitution of dacarbazine for procarbazine is a big deal. There was a great paper that was just published, even though I can't come up with the name but it's from the British, I think, looking at the gonadotoxicity and the general stem cell toxicity of Biacop compared to Bicodac. And it's amazing. You pick up mutational signature in the offspring of patients who had, including in the male offspring of patients who had Biacop. Like, unbelievable what we're doing with Biacop. So I think Brecad is a very different regimen, I think.
One quick question, Dr. Armand. So what about the role of CAR-T in Hodgkin? CAR-T cell therapy in Hodgkin's?
Well, I turn it back to you guys, but unfortunately, I think so far the CAR-T experience has been disappointing, mostly in its duration of benefit. And it may be all the same, right? Allotransplant before checkpoint was really bad in Hodgkin, right? The PFS in registry studies that you conduct is like 25, 30%. It was one of the worst lymphomas. And I think probably all of it is because Hodgkin is so good at hiding from the immune system. That's what gave PD-1. It just happened to be the pathway that disabled a lot of that. But it may be why CAR T by itself also may be less effective because it's just good at hiding from T cells. So I think we haven't cracked it. There was a recent paper in Blood from a Spanish group looking at a different way of manufacturing CD30 CAR with maybe more naive cell that looked better. They had better response rate and better durable PFS, but it's very early. I don't know what you guys think about it.
I mean, there were patients from the Baylor and UNC cohorts that were 2, 3, 4 years out, still in remission. And at one point, there was a company trying to launch Tessa. Yeah, and I don't know what happened there.
They stopped because it wasn't good enough.
I think they went out of
They
business.
killed the
right?
trial.
I mean,
Yeah.
but every time I tried to put a patient on that study, you know, I would try to send them to Chicago. There was always a problem with the study. It was temporarily closed, or they moved their manufacturing facility. There was a lot of, I'm not sure if it was all just based on data. I think it was based on logistics.
So I think good try, Naren, to derail the discussion. So I'm gonna loop us back in, gonna check with the audience and see if they, yeah, so Jasmine.
So, is it with checkpoint inhibitors? We know that at least it's not always clear about the PET. Are we still going with the two, PET scans after 2 cycles when they're getting Nivo AVD? And are we still using the same principles of PET adapted evaluation of patients? Though the recipe is still 6 cycles. So, any thoughts about that? Because I struggle with that issue.
So thank you, Jasmine. That was my next question is I think the consensus in frontline is that most of you, even the contrarian, is using Nivo AVD for most of the advanced stage disease patients, but you make a good point about maybe at least discussing the option of breakout. But how are you incorporating, are you doing a PET too, which I suspect most of us are doing it, but what do you do with that data in the absence of clear progression? How do you interpret a Deauville score of 4 or maybe a 3?
I think it's a very important and intriguing question, I would say, especially with the use of checkpoint inhibitors in the frontline treatment, right? Because we want to be absolutely certain that it's actually progression and not pseudoprogression, right? So, but to your point, if we all know we have been seeing the PETs, we know whether it is a pseudoprogression or we think we know whether it's a pseudoprogression or a true progression, but if there is Deauville 3s, I truly don't put too much onus. It's usually the Deauville 5s that I struggle. I mean, I still try to make sure, I mean, if it is a florid progression, then I don't biopsy it, but if it is there is ambiguous lesions, then I just keep going as long as the avidity has gone down consistently. Because again, the way the Deauville scores are rated are, you may have more than the liver background avidity, and it's still called as Deauville 5, but then 20 to 5, the SUV coming down from 20 to 5 is still a Deauville 5 on a PET, but we all know that actually the patient is responding, right? So it's all in the context of what true Deauville are we talking about? Is it from 5 to 10, or is it 20 to 5, right? Because both are Deauville 5s, and then in the former where it has come down from 20 to 5, I keep going, right? But whereas 5 to 10, I take a pause and then probably discuss what to do next with the patient.
So you're more thinking in terms of the delta SUV, not necessarily what the individual Deauville score had to be like. Does anybody has a different thought?
I think interpreting interim PET is always a little tricky, especially when people are on checkpoint inhibitors. And with the regimen having such a high success rate, unless you're almost 100% sure that it's progression, I think you either, because even if you get a biopsy after 2 cycles and you see a little bit of residual disease, what does that mean? I would just press on until it becomes more clear. And sometimes you do have to get a biopsy of a new lesion or a growing lesion to really prove that.
So do you not look?
Or don't look.
No, do you not look? I was going to ask you. What do you do?
I mean, I think we same thing for diffuse large B-cell lymphoma, right? We still do interim PETs, even though they're not going to be guiding treatment. They're just prognostic, essentially, for us. And I think it's more concern for progression. And I do think, if there's actual progression on an interim PET scan, that is concerning. PETs are still prognostic in this setting. Maybe they'll be overtaken by ctDNA at some point, but yeah.
So Philippe, you don't do PET after 2?
Well, I think we shouldn't, but I do it.
right?
It's so hard, right? So it's so hard to get out of this mode, but I don't think we should do it for all the reasons you discussed. And it's one of the things that you think about, like we use these resources, financial resources, we expose patients to radiation with no data. These are not PET-adapted regimen. Say, why are we doing it? And unlike DLBCL, I think your point's well taken, but the thing about Hodgkin is the chance that you're going to have a Floyd progression after 2 cycles of whatever, Brecad, Nivo-AVD is really low. Large cell lymphoma, you're going to pick those up. But Hodgkin, is that really what, do we need to do a PET after 2 cycles to pick up progression? Like, and is that not going to be clinically obvious for most of these patients? So I think the answer should be we don't do PETs. I'm being a hypocrite.
I mean,
Well, you know, it is changed actually. I think in the Nivo-AVD, BV-AVD, Brecad, if I remember, no, sorry, not Brecad, of course. In the Nivo-AVD, I think there's some caveat around that, I think.
We are actually doing a real-world study of patients receiving Nivo-AVD across 20 US sites, hoping to present for upcoming ASH and submit for an abstract. So one of the things in that we are trying to capture is what are the practice patterns, right? We all know that in the S1826, it was not a PET-adapted study, but in reality, are we actually doing what this trial did? Probably not, but we are capturing that. It'll be nice to see how many sites actually did versus did not, and how did the outcomes differ. So it would be intriguing again with all the caveats of a retrospective
I think
study.
you will have a hard time finding a site that doesn't do that, right? Because even with Echelon 1, PET2 wasn't really prognostic, right? But we still kept doing PETs. But so let's talk about a hypothetical uniform world where, let's say, all of you have decided to give Nivo-AVD to frontline patients, right? Because practically that's what we are doing for most of our patients now. So I'm gonna maybe for Philippe and Tim, maybe a more difficult scenario, and for Urshila and Naren, maybe not an easy but less difficult scenario. So Philippe and Tim, how would you approach a Nivo-AVD treated patient that either progresses while on therapy, that admittedly I've never seen, or somebody who relapses, let's say, within 3 to 6 months? Again, a scenario I've not seen, and maybe a scenario that I have seen for Urshila and Naren, like patients who maybe relapse beyond 6 months. I've seen a couple of patients now. So how would you approach those patients? Is there a method to madness? Would you still do a checkpoint inhibitor-based second-line therapy, or are you gonna go to BV-based regimen, or are you gonna play both sides and just go to BV-Nivo in that setting?
I mean, if you just compare salvage regimens, the regimens like Pembro GVD look, that has the highest PET negative CR rate of really any salvage regimen. Now that was in an era where people weren't getting checkpoint first line, so it's hard to know whether to extrapolate that to the scenario that you just brought up. But I think our goal with second line therapy should be to try to get them to a PET negative CR and then to transplant until we have data to suggest that there's a equally effective alternative path. But
what's your regimen?
maybe Naren's study can capture that patterns of second line therapy for the few that failed, but because we don't really know. But I think it's, and there isn't really a BV plus GVD or that type of a regimen. I mean, that would make sense to do a BV based salvage, but
We have
I don't
BV
know.
Benda, right? Like
Or BVIs.
Yeah.
I think would be
It's true, you could do that. I don't remember what the PET negative CR rate was with that, but I don't think it was as high as.
So it looks like, Tim, you're leaning towards a very early failure or progression. You may go to a more BV-based regimen, and
I guess was been conditioned to use Pembro GVD the last few years, but in the scenario you're bringing up, it would be really nice to have to get BV into the salvage regimen. So maybe BV Benda. I don't know what the right answer is there.
So Philippe, what about you? I've admittedly not seen within a 6-month failure so far. Eventually, I think we will. So,
We have one already.
so how did you approach that patient?
Well, I think for me, the two options that make sense are pembro-GVD, as you're saying, or BVIs. The nice thing about those two options is that they're pretty much completely orthogonal. And for Hodgkin, it may not matter so much when you get to transplant, as long as you get there. So in theory, I think you probably could do either and then use the other for rescue. Because of this chemosensitization thing, because there's some data out there, although it's very weak data, that when you treat past progression with PD-1 or you chemosensitize patients, there still may be a benefit to keeping the PD-1 on. I think I might favor the pembro-GVD, try that, and then BV consolidation. And then if that doesn't work, BVIs. But we need real-world data for this.
So I'm going to ask you, it's a hypothetical question. It's kind of based on somewhat of your data, at least in an allo setting where you and now a couple of groups from Asia have also shown that the checkpoint inhibitors tend to last for a while, right? At least their PD-1 inhibition lasts a few months. So do you really need it if it hangs around that much?
It's a good question. Of course, we don't really know. There was the paper that I'm referring to was the one that was published by Cédric Rossi in like 2018 or something, which is a French study, one of the first chemosensitization studies. And if I recall correctly, what they did was they looked at patients who got chemo post-PD-1 failure, and they had very high response rate, but some of those patients got PD-1 plus chemo after PD-1 failure and did better than those that had chemo alone. That's the only piece of data that I'm aware of to say, well, maybe it still makes sense, and you don't lose that much from adding pembro. So I think if you don't think there's a benefit, I would just do BVIs, because then you might as well use BV. But because we don't have a BV plus PD-1 plus chemo regimen yet, I think you're sort of stuck having to pick between more PD-1, which may or may not help, or BVIs. The nice thing about more PD-1 GND, is that you can still get BV and consolidation. So in theory, you can still get the benefit of BV in second line. But I don't know what you guys.
So I smell a little bit of, like, I thought you were a recovered transplanter. So this is sort of sounds like Jacopy, right? Your GVHD has failed Jacopy, but we don't stop it. We just keep adding things. Jacopy never goes away. So Urshila and Naren, your scenario, relapse maybe 6 months or beyond.
Yeah, I mean, I think Alison Moskowitz's study, they had some patients who had checkpoint inhibitor. I don't know if it was just on trial or what in the first line setting, and they showed that they were able to, to use the pembro-GVD regimen and still rescue a lot of these patients or salvage a lot of these patients. So I would still favor including a checkpoint inhibitor plus chemo-based regimen in that setting for sure. And we've done it. I've done it for a few patients too, and it's worked.
After nivo-AVD? After nivo-AVD failure?
Yeah.
Late failure like this? Or early
Yes,
failure?
late failure in that situation, yeah.
Okay, so
Yeah,
do
no,
you
I
disagree, Naren? So
Yeah, I completely agree with that. Definitely, the scenario, as you rightfully said, is relatively easier because definitely we would give a checkpoint with chemotherapy.
Like I was expecting some fight, right? So people to disagree.
Well,
you're a very agreeable group. I wanted somebody to say, no, you're wrong. This is how I do it. Right?
I do want to ask actually for this early relapse setting. There wasn't a lot of mention of BV-Nivo as a salvage option, and so you guys don't have a lot of faith in that.
Because I think in the BV-Nivo, if I recall correctly, the benefit was more seen in the patients who were relapsed rather than refractory, right? And that's probably why I don't use in refractory patients that combo just because of that.
Right, I agree. I think if you look side by side, again, it's side by side, but BV-Nivo is less good than all the real PD-1 chemo. And if you've already burned through one of these drugs, potentially by using nivo-AVD, where you think maybe checkpoint doesn't give you much, you might be giving single agent BV in second line, which is not great. So it might work, but I would be worried about it. I don't use BV-Nivo in second line unless somebody can't tolerate chemo or whatever.
Okay, so our theme right now is whether it's a relapse early or later, it's still going to be something checkpoint based, likely in combination with chemo. So Dr. Iqbal.
Yeah, just kind of a simple question, but I know we didn't touch about early stage, but we know that those patients relapse too. So just wanted to see if there's any different way that you approach salvage in that setting? If it's an early stage patient relapsing or there's just no difference, you just approach it exactly the same. Point I'm thinking that if it's a young patient, you're trying to avoid chemotherapy in that setting, in the salvage, just kind of from a long-term toxicity standpoint, or you're really just thinking this is the same patient's relapse, we're just going to, do BV ice or Nivo ice and that kind of regimen. So.
And Madhya, this is assuming it's an early stage patient.
Early stage patient who relapsed.
Basically ABVD based.
Correct,
right?
exactly. So that being my point, that this patient is previously chemo exposed and you're going to give them more chemo in the transplant setting, in the salvage. Are you approaching these patients differently, or you're just thinking it's the same?
I mean, I think if it's early stage and early relapse, then those patients I still would try to take to transplant. If it's a late relapse, I mean, the old data for transplant really showed PFS benefit, but not OS benefit for late relapsers. So you could, have a discussion there, although the PFS is still, to Philippe's point, you have an opportunity to cure these patients. So I think we still would generally, if it's a younger, otherwise healthy patient, try to make the case to just do the transplant, because if then they fail again, it's not going to be any easier, to collect stem cells, or if someone's borderline age-wise, they're not getting any younger, so it may be harder the next time around to do the transplant. The other point I would throw out there is you get these patients who are early stage and they've had BV, and then they've had a checkpoint inhibitor, they've had a transplant, and then the discussion comes up about allo, maybe. I would throw out there, don't forget about radiation therapy, because that really was the first curative treatment in Hodgkin's, and we're trying to avoid it whenever we can. But if you compare the toxicities of radiation to allo, if they have something that can be contained within a radiation field, that may be the option with less toxicity for a patient like that.
Okay, so let's jump into the more controversial question, right? So in the second line setting, you have a relapse patient. Is there anybody, assuming the patient is young, which most of Hodgkin's are going to be young when they fail therapy, right? So let's not talk about an older, unfit patient. Is there a patient in second line setting who's otherwise very fit, very healthy, that you wouldn't take to an auto transplant in the second line setting? And I'm asking this question for a reason, because I'm sure all of you are familiar with the ECOG study that is with the NCI lymphoma committee now. I think it likely got approved, which is going to look at this patient population. So your thoughts about that study? Do you think there is equipoise in offering that study for the patients?
I think I remember first hearing about the study and being very concerned about, we're gonna randomize people to not receiving a transplant. But I think after hearing Alison Moskowitz's presentation, especially at the German symposium last year, where they, that 61% PFS in patients who just underwent pembro maintenance, those patients, for the most part, they were actually, again, able to salvage and get them to transplant at the point of relapse. So, I mean, yes, I think in a younger patient, you're outside of a clinical trial, you're going to want to give them every chance to, a cure up front is better than waiting. But there are a lot of, or maybe a subset of people who really don't want that and want to see if they can avoid, transplant, or it's not in line with what they want to do, and maybe there's a chance they can. And I think, if you have a trial that's able to study that, I think it's reasonable.
That also begs the question, the role of early versus late auto transplant, right? So that's what I was thinking when I was looking into the study. Is yes, it's great, to Urshila's point, that yes, at least it's heartening to see that there is this safety net in place in the event that there is progression. But also in my mind, I was thinking, again, and this debate has been going on in other non-Hodgkin's lymphoma for quite a while, is early versus late, how much would that be detrimental? Should we actually do the auto at a later line versus trying to do in the earlier line? Again, on the contrary, if I have to play the devil's advocate, yes, we will also preclude a high-dose chemotherapy and autologous stem cell rescue, which we all know is not easy to tolerate, or relatively tougher to tolerate for these young patients because that can have some morbidity concerns for a lot. So it's not a slam dunk like, okay, this is great, but it just makes me a little also pause. I want to hear what Tim and...
Okay, so this is like Dr. Usmani is telling me we are over time. So this is going to be the last question. I'm going to maybe have Tim and Philippe chime in. So you touched about we don't know how to risk stratify patients at relapse, right? So if we can truly identify a low-risk patient, I think particularly with your data with Reed Merriman, that later transplant even helps after 3 prior lines of therapy. So the way the ECOG study risk stratifies, high-risk patients get transplant. The question in that subset is different. The low risk or the standard risk is defined as relapse beyond 3 months if you didn't get checkpoint inhibitor, or 6 months, totally made up, if you got checkpoint inhibitor, and you have a radiatable disease. So 4 or less areas, or I think 3 or less radiatable areas in a field where you haven't had radiation before. Is the study stratifying the patients correctly is the question. Is that the patient you would feel comfortable randomizing to no transplant option? So this is the 3 to 6 months cutoff, and then no more than, I think, 4 areas of radiatable disease.
It was sort of a made-up cutoff in some ways, but they were extrapolating from some available data, and it's reasonable, I think. I think it's going to be a discussion with the patient, and if it's somebody who really wants, an opportunity to try to avoid transplant, and they're willing to undergo randomization, it's a reasonable study. If it's somebody who's telling you, I just want to deal with this one more time, hit it hard, and let's be done, it might not be the right study for someone like that.
I agree, and I think it ties a lot of the last questions together, your question about early stage and the question of whether it's reasonable. If it's going to be done, I think to do it on trial, as you say, Urshila, and to do it in patients in whom you can radiate the disease, and to use checkpoint. I think you look at the pediatric data, that was that the study that was on the right of the slide was BV-Nivo, right? If no CR, BV-Benda, and then at any point CR, radiation, no transplant, PFS 95%. Okay, yeah, those are the patients to do it in. So I think it's a very reasonable question, especially if you can use radiation. The 3 to 6 months, I don't.
Well, thank you so much for joining. It's like I actually learned a lot by listening to you guys. I had questions about checkpoint inhibitor resensitization and allo transplant, but Dr. Usmani has spoken. So thank you so much. A round of applause to everybody.